Right. Welcome, everyone, to today's UK Healthcare's Behavioral Health Community of Practice. We're thrilled that you've chosen to spend time with us again today. I'm Mark Woods, and I work as the Chief Nursing Officer for Behavioral Health here at UK Healthcare. And I have the privilege of filling in today for Trudy Matthews, who couldn't be here with us. But for those of you that might be counting, this is our seventh session. Knowing that everyone has been to every single one of those, I still want to point out that if you missed one or you want to go back and review one, that you'll have the opportunity to, we have the website that you can refer back to be able to get caught up on some of them or revisit some of those things as you so wish. It's on the UK Healthcare Kentucky Regional Extension Center website. And I think that website will be show. I think maybe we can put that in the chat, but I know we have a slide a little bit later today that will also sort of highlight that for you. Speaking of chat, I want to emphasize to those of you that are joining us that we encourage engaging interactions and discussion. And today's going to be really important that you do just that. You'll have the opportunity to engage in the chat, but also some of our Mentimeter polls. So you'll want to get your mouse and phone handy to take pictures of our QR codes to participate in those polls. And during the presentation, you'll have an opportunity to post questions in the chat, but also we want you to share things in the chat as well as we move forward. So this is a really good example of how we are continuing to learn from one another by sharing and engaging in discussion. So if you're less familiar with Zoom, at the bottom portion of your screen, you should be able to see your Zoom button and your chat button. Click on that and you should be able to enter your question or affirmation. Maybe you can say, you know, hey, great job, or we're doing the same thing, hopefully. So we've got a great group of presenters today and experts for today's topic on primary care and mental health cross-specialty collaboration. So this is an especially important topic because what we know is individuals with mental health needs often turn to primary care providers as the first point of contact. A lot of times that's where they receive that initial sort of point of discussion around their behavioral health needs or their mental health needs. What we also know is that sometimes, though, our primary care providers may not always have the specialized training or resources needed to provide the best possible care for these patients. So by working collaboratively with mental health professionals, sometimes primary care providers can improve access to mental health services, provide more comprehensive care, and arguably the most important part, elevate and improve patient outcomes. So today's webinar will explore some of those strategies and best practices that have been found useful in promoting cross-specialty collaboration between primary care and mental health providers here at UK Healthcare. So let's get started with our first presentation of the day. I'm delighted to have with us Dr. Mandakini Sadir and Dr. Corey Arena from the Department of Pediatrics at UK Adolescent Medicine. First, a little bit about Dr. Sadir and Dr. Arena. Dr. Sadir is an adolescent medicine physician, division chief and medical director at Division of Adolescent Medicine, Department of Pediatrics at University of Kentucky, Lexington, Kentucky. She is board certified in pediatrics and adolescent medicine. She currently serves as chair of Adolescent Health Task Force for Kentucky Chapter, American Academy of Pediatrics. Dr. Sadir assisted in completing the behavioral mental health section of the U.S. News and World Report Novel Hospital Survey, and she has been selected to serve on the U.S. News and World Report Best Children's Hospital Working Group on Pediatric and Adolescent Behavioral Mental Health. She continues to provide comprehensive and patient-centered care for adolescents and young adults and is very well versed with common mental health concerns in the adolescent population. Dr. Corey Arena is a dual board certified family and psychiatric mental health nurse practitioner and graduated from the University of Kentucky College of Nursing in 2011. During her time as a nurse at the bedside at Kentucky Children's Hospital, she developed a passion for health promotion within the pediatric population and attended grad school to gain knowledge to improve health at the individual and system levels at Eastern Kentucky University College of Nursing. She then obtained her Doctor of Nursing Practice at the University of Kentucky. Her professional interests include addressing youth adversity, reducing mental health stigma, observing adolescents where they are, understanding their value and strengths, and most of all, helping them grow into the most authentic versions of themselves. I absolutely love that last part. So she enjoys spending time with her wife and 2 dogs, Finn and Bo, as well. So guys, we want to welcome you today to our session.
Well, thank you, Mark. I think I can get started. Maybe the next slide. So, well, we're just going to briefly talk about our adolescent medicine clinic. I'll highlight some relevant data and kind of share our recommendations and things that we do in our clinic that have really helped us to provide the mental health care for our patients. Next slide, please. So many of you may be familiar with adolescent medicine clinic, but I really like to highlight, and Corey and I always talk about adolescent medicine clinic is all about giving these teens the wings so that they can fly. And that's what our clinic is all about. I think we provide a comprehensive, interdisciplinary, inclusive healthcare services for our 12 and older teens and young adults. And I think as a clinic and as a division, I think we feel privileged and are grateful because we have this multidisciplinary setting where we have physicians, nurse practitioners, physician assistants, mental health providers, dietitians, and social workers, where we all work together to meet the unique physical and mental and emotional needs of teenagers. And this is where it takes a village. And so I'm so glad that we have all those professionals in our clinic to be able to help these patients. Next slide, please. I just kind of wanted to highlight the data, just as everybody's familiar, and, the mental health disorders. And as we can see, the onset of these mental health disorders kind of start as a teen years, as adolescents, and the whole depressive disorders, anxiety disorders, and a lot of mental health can have an onset as a teen. And I think this is kind of highlights that it is not just in US, but across several nations and globally, that is a huge concern. The mental health burden is kind of all over different countries, and including developing nations as well. Next slide, please. And from a suicidality standpoint, we all know teens, the top 3 causes of death is accident, suicide, and homicide. And unfortunately, suicide became the second most common cause of death for children 10 to 14 years of age. And that's really sad. In 2016, it used to be third, and now it's the second, and it is the fastest growing. And we see a significant racial disparity. And I just kind of wanted to highlight some numbers. With the COVID pandemic, I think we kind of all felt the ER visits for self-harm while it went down, but we saw a pretty big increase in inpatient hospitalization, only because these kids were coming with serious thoughts about killing themselves and harming themselves, and that is resulting in inpatient hospitalization. So I think the suicidality continues to be that concern. Next slide, please. And this is just another CDC data kind of highlights the ER visits for mental health. And we can see how, there was a big increase. The first box is, is looking at overall mental health for children and adolescents. And, there was a big sort of a decrease, and then it started to go up, then it went down and started to go up. But overall, it continues to still stay high. And then the interesting part is eating disorders. We have seen a pretty significant rise in eating disorders. And this is something that we have seen in our clinic. There has been an increase in inpatient hospitalization, and eating disorder is not going anywhere. We're going to see a lot more of that. And there are multiple factors that are playing a role. And this is something we need to be aware when taking care of teens, that, eating disorders are the 3rd most common chronic condition. And I think the prevalence is increasing, and we're seeing kids at a very young age, as early as 9 or 10 years of age, are presenting with body image concerns. And data kind of shows that how pandemic impacted eating disorders and the ongoing rise, and it hasn't gone down to pre-pandemic levels. So something to be aware that this is an ongoing concern. And then this, tic disorders for some reason, they kind of went up during the COVID pandemic. So just kind of seeing mental health, just kind of an overview of where we are in terms of mental health for adolescents. Next slide, please. And, again, anxiety, depression, it's kind of have doubled during pandemic. And it'll be interesting to see where we are going to be. We all have felt an acute on chronic mental health crisis. And I think this is only going to continue to get worse. Next slide, please. So this is where I kind of wanted to highlight, and Corey and I are going to discuss what we did in our clinic and what we do for mental health. So for our patients that we see, we do a universal screen for depression, anxiety, and suicide screening. We kind of implemented the ASQ that we do for all our patients, new patients, for well child checks, and patients who are coming in for a consult. So as a universal, we do this for everybody. And I think the PHQ-9A is a great tool for teens, and it's a validated screen for 12 and older. What we did was we added the ASQ questionnaire, which helps with screening us for suicidal ideation, because there was one study that looked at that PHQ-9 sometimes may miss the suicidal questions, and teens may not be able to express suicidal ideation, but ASQ was a better tool. So we implement that for our patients. And then we have certain workflows where when they're positive, what's going to be a next step, doing safety planning. And we do have a referral process in place where we use the EPIC. When we have a positive screen, we do the Stanley Brown template that is incorporated, safety planning, and how we do a referral to our mental health providers. And we have a triage process in place for mental health referrals. So we have a certain criteria that we set for sort of an urgent, and emergent referrals. And we really work with our team as to kind of make sure they are seen in a timely manner. And we also provide additional resources for community. So we've created a handout where we have a list of mental health resources and talk about, other resources that they can access, including the 988 number and information around information on the American Foundation for Suicide Prevention, the parent kit. So we have a certain streamlined process with screening, positive screens, what we do next, how do we triage, and do a referral process within our own clinic, and how do we make sure that these patients are being followed up on a pretty timely manner between the medical and mental health providers. And so I'm going to have Corey take on to the next section around how do we, teenagers are always about, well, I don't want to I want to talk to anybody. And then how do we as a provider really have to talk to them about, what, this is important. Yeah, but I don't want to talk to anybody. So Corey is going to talk about her skills that she uses to kind of influence her patients to get into therapy.
So thanks, Dr. Sadir. So recommendations from our perspective, I think that we have, the last few years, as we all know, we felt the stress on our shoulders as far as the concerns with behavioral health and access to. So, and I really love the questions, or, what you guys had said, okay, maybe we could focus on these things. And Dr. Sadir and I thought that these three would be important, because we have primary care providers without behavioral health providers, influencing patients to see a behavioral health provider and managing care together. And when we don't have all those resources that we would like to have, it's really important that we give our patients what they need to be able to get services outside. There was an example of when in adolescent medicine, post-COVID, we had no room in our clinic for patients to see behavioral health providers. And there was a time within our clinic where we were maxed out. And that's part of why we had ramped up the referral page that Dr. Sadir just referred to, because it didn't feel right for us to have a medical home with these resources, but there was a time that we did not have behavioral health providers for patients, for months. So we felt that stressor and really tried to work together as a team to figure out a lot of processes. a lot came from that time. And then for influencing patients to see a behavioral health provider, I think it's really, really important for us to take an introspective look and understand our own limiting beliefs and biases that we have, and be compassionate to ourselves too, and really understand how we feel about mental health within the primary care world. How confident are we about being able to make suggestions and recommendations? Because when we do a screening and we find a problem, we want to be able to say, okay, here's how you fix it. And it's not fun to not have those tools. So understanding what our own limitations are, I think, are really important. And it's also helpful to seek our own mental health therapists, especially with the stressors of working in healthcare. So UKHR has a really nice, has a lot of great wellness specialists that, and if you're, wherever you are, if that's something that you can do, it's always helpful. Also using the appropriate language, expanding our knowledge base to address mental health confidently with parents, especially when we work with kiddos. We want to feel confident in saying this is something that would be important. And appropriate use of language, we could go a lot of places with that. But I remember it was when I first started in adolescent medicine, and there was this kiddo who his PHQ-9 was super high. He seemed really sad, down, depressed. And I was telling him, like, we know you need to probably start some medication. You need to go see a therapist, just looking at it a very not that soft. So I went to Robin Morris, one of our LCSWs, because he was refusing to see us or to see a therapist. And I said to Robin, like, what do I do? This is what I said or whatever. And she kind of slowed me down, and she was like, maybe you could look with him at the PHQ-9 and say, wow, it's really hard that you're feeling like this. This must be really difficult, and provide some empathy with that. And I did that, and that brought a new connection that he was able to. So kind of slowing down and having that empathy. And I think that's part of self-compassion too. We have to be able to know ourselves and be able to access compassion too when we're talking to kiddos. So we're so lucky to have LCSWs here. I don't know if this is an appropriate recommendation, but I think everyone needs LCSWs working with you, because their perception and their perspectives are just incredible. And then managing care together within our teams, making sure that we have psychologically safety and ensuring a judgment-free environment to discuss the struggles of difficult practice challenges. Some of the most important times that we have growth within our teams is when we're having really hard conversations with each other about how we feel maxed out, or this process isn't working, or just making sure that we're supporting each other and not just putting on a good face, because that's what we're supposed to do. And then having interdisciplinary practice, establishing collaborative relationships internally and externally. An example of that is, and Dr. Sadir is our chief of adolescent medicine, and she's done an incredible job of listening to everyone, as far as dietitians and LCSWs, NPs, and other physicians, and just the importance of having time, especially for patients who have eating disorders. We've recently started a multidisciplinary clinic that allows a 2-hour block, even though it might not be the best billing, it might not be that lucrative, but she helped us to have that time blocked off to where we can have, a medical provider and a dietitian and LCSW do a collaborative intake with a patient with an eating disorder. And although it might not bring the most money generating thing, it provides a lot of relief and help with each other. So, but I don't know if there's anything else you want to mention, Dr. Sadir, but those are recommendations.
Yeah, no, thank you, Corey. I just wanted to add on to that, two things. One is going to be around therapy. And I think how Corey mentioned, empathy and compassion is so important, try to really understand from a patient's perspective. The other thing is to also understand and be aware how therapy works. And I think sometimes that's important. It's more than just talk to somebody, right? And for teens, I just know they don't like to talk to anybody. And I think a lot of time I spend on, it's not just talking about, I understand it's hard to share things and it is hard to just open up to somebody that you don't know. And I think it's important to help them understand what therapy is all about. And then there's more to just talking to somebody. So having that understanding and knowledge, what are the different types of therapy, how therapy works, I think just a underlying just general principles. And I think this could be something that as medical providers, we may need to become more aware so that we can really help parents and patients understand the importance of mental health therapy, what it does for them, and that it is just more than talking to anybody, and especially for teens. For adults, it's different, but for teens, it's a very different thing. And when we get a little bit of a, pushback, and then we shouldn't stop at that. Well, the kid doesn't want to do therapy. What can I do? And I think really help them understand and be there for them. If they're not ready for therapy now, it's okay. Just come back for a follow. Let's just figure this out. Let's just give it some time. But be there for them can be a way to build that relationship for those kids. And regarding collaborative practice, and this is something that we are trying to build on eating disorder, where we know the resources are not out there. And our clinic, obviously don't have a lot of resources for eating disorder as well. And this is where it's about how do we reach out to community providers. And this is one of the things that I'm working on is let's just figure out who are our therapists in the community, who are the therapists who provide eating disorder care, how can I collaborate with them? And build that relationship, because this is again a team approach. So sometimes when we don't have things in our clinic, then figuring out who are our people and our team and how do we develop that relationship to provide and meet the needs of your patients. So
That's fantastic. Thank you so much, Dr. Sadir and Dr. Arena for sharing all of your expertise. That was a lot of different things that you guys are doing. And what I like most is that it's not one thing. It's not that, you're using nurse practitioners and LCSWs, but you've even brought in the nutritionist to sort of help augment and flavor some of the assessments that you guys are doing. That's really cool stuff that you're doing. So we want to, at this point, we want to open it up for questions. And for Dr. Sadir and Dr. Arena, we've actually got a couple. And so I think the first question we received was, how can a private practice have access to refer patients to, I would assume, a therapist or an LCSW? Any thoughts on that, Dr. Sadir, Dr. Arena?
One thing that, and we're happy, I'd be happy for us to send, our information out about referrals and people in the community. But one of the things that we've done is ask patients to actually call their insurance to see what is covered under the plan, and starting there, because we could give recommendations, but if it's not covered, that might be a huge barrier for them. So starting there and then developing a list within your own practice is something that I would recommend, and I'd be happy to send you our referrals, Dr. Woods, if you want to send that out too.
Absolutely. I think it'd be helpful. I like that. It's also one of those things too, where you sort of, you almost have to reach out, right, to other practices or therapists to sort of maybe set some of that up, have conversations almost from a business perspective, but it's not a business. It's really about continuity of care. And so I think that's an important piece is, maybe identifying who's out in your community, what things do you have available to you, and then reach out to them and find out, are they accepting patients? Are they not accepting patients? Do they only take certain types of insurances? And then, of course, there's the community mental health centers that we have in our areas as well that can maybe help with some of that, for sure. Any other questions from our audience at this point? I encourage you to put them in there. In the meantime, I did have one question, guys. If we could slip back a couple of slides to the table that you guys had, I want to encourage everyone to go back to our resources and access this slide when you're thinking about your own practice, because I think the team put together a really good diagram of, how can they improve it for their patients in the first column, and then for themselves, right? Influencing patients to see a behavioral health provider. That's a tough thing to do. And then for your teams. I think that's something that is a nice takeaway for all of us in primary care practice as we begin to try to make better connections for our patients and provide better care. The last question I had for you guys before I let you go, if we don't get any other questions, is motivational interviewing. You talk about sometimes you come across a patient that may be somewhat resistant to going to getting treatment or therapy. Do you guys engage in motivational interviewing? And do you have a moment to speak to those that may not know what that is even about, if you do?
We do. Dr. Sadir and I actually did some HPV motivational interviewing. I can't remember what it was, Dr. Sadir, rowing with oars or something, a couple of years ago. And one of the things with motivational interviewing is really understanding what the barriers are. Dr. Sadir kind of touched on maybe it's not a perfect time, for a kiddo to be in therapy, but having an understanding of what their fears are, asking open-ended questions. Dr. Sadir, you could probably speak more on motivational interviewing too, but.
Yeah, I think we do engage in motivational interviewing depending on with the patient. However, since we are fortunate to have therapists, a lot of the work we tend to refer to them for a lot of those behavior change. But even in the beginning, I think motivational interviewing does influence not just for therapy, but for every aspect, right? So we did for the HPV vaccination, how there was a lot of vaccine hesitancy. So it's important to engage in open-ended questions, affirmations and reflection, and, really looking at how do we work on some of those changes. And at the same time, I think one of the things that I've kind of learned as doctors, sometimes we are, we just learn to give them information. And the thing is that parents don't want information. They want us to understand where they're coming from. How are we sensitive to their needs, and how much are we ready to work with them based on their needs and where they are. And so motivational interviewing techniques can really help with that, to understand them and how we can influence behavior change. And then again, we can't change everybody, right? And again, but we can certainly make and influence changes in majority of our patients. And so I think those motivational interviewing skills can be very, very helpful. But again, I think a lot of the use of motivational interviewing in terms of treating mental health conditions or substance use and other things, I think a lot of our mental health providers kind of engage in that. They kind of use it more often, but we kind of do it based on some of the medical and, certain elements of it in terms of change.
It kind of cuts across all needs, right? It's just a way to kind of move someone along the steps of change, right?
Right. Yeah, no, it was really helpful. So we did do some training from medical providers, just like how HPV vaccine is one example. Vaccination hesitancy. If you want to give COVID vaccine, how do we motivate people? Yeah. Other substance use and other things.
And that's something that given all the information, that's kind of what I had experienced with that patient. Dr. Sadir and I learned that's called a data dump. You throw this data at people, they don't care, really. And so we spend that time doing this data dump, and that is not motivational interviewing at all. It's very much one-sided. So making it a partnership, I think, is the biggest part of motivational interviewing too. So
awesome. Well, guys, thank you so much for your presentation today. It's been great. I don't see any other questions, so I think we're going to move on to our next presenter. So our next presenter is Joan Scales. She's the Director of Oncology Social Work at the Markey Cancer Center here at UK Healthcare in Lexington. She has overseen the exponential growth and service offerings to Markey cancer patients, including implementation and continuation of distress management, expansion of counseling services, and additions to both social work and nutrition staff. Joan and her team also work on national and local research opportunities, including the implementation of evidence-based tobacco cessation programs in the Markey Cancer clinics. Employed by UK Healthcare for over 13 years, she has worked with both pediatric and adult oncology populations. She has some previous experience with the Leukemia and Lymphoma Society, as well as Hospice of the Bluegrass. Joan earned her Master's of Science in Social Work from the University of Louisville, Kent School of Social Work, and lives in Lexington, Kentucky with her family. So thank you so much, Joan, for being here today and speaking with us.
Thank you very much for having me today. I'm happy to be here. So I want to go on to the next slide. I'm just going to jump right into it. So we are a unit group here, I think, over at Markey, refer to ourselves as psych oncology. So we are composed of social work, we have dietitians, we have a financial advocate, and forthcoming is our new patient navigator position, which we're really excited about. Our social workers will help. Our LCSWs are doing some of that clinical work, but also doing a lot of that psychoeducation and at times addressing barriers to care, whereas our CSWs are doing mostly just like barriers to care and helping our patients make sure that they're successful as they come through treatment. We know that healthcare crises cause a lot of financial debt, a lot of financial burden for our patients. So we also work with our patients to help with that, alongside with our financial advocate, who's really helpful in addressing any kind of billing and insurance type issues that come up throughout the treatment. So it's a great service to be a part of, and our patient navigator is going to be helping a lot more with just some of those barriers. So we're going to be learning a little bit more about that one as we move forward. Next, please. So how do patients access us? How do they find us? And our main mode of people finding us is through our NCCN distress thermometer screening. And that is a tool that came down from the Commission on Cancer. And we started this process back in 2014. Patients will rate their distress on a scale of 0 to 10 and have a list of problems that they can check yes or no, or concerns, excuse me. They check yes or no, like, yes, I have problems with my appearance. No, I don't have problems with depression. And it covers the domains of family, physical, emotional, spiritual was recently added just last year. So we were really excited to actually include that spiritual component now and asking specific questions about spirituality. And then just the practical aspects too. So, you know, I'm having trouble with my utilities or what have you. So that's our primary means of getting to people. And they have with that, the thermometer piece of it, if they score a 7 or above, then we get to see these patients and follow up with them. And we try to do it in person while they're here at clinic, but oftentimes it can be just a phone call follow-up where we are reaching out and trying to get them and access them. Slowly, we're making our way and kind of within the community. People are recognizing, hey, if this person has an oncology diagnosis and they're here at UK, I can refer them over to Joan and her team. So we get a lot of referrals from our partners here at UK Healthcare, as well as a lot of cancer community partners. A lot of people within the community that we work with who will say, hey, I know this patient lives at Markey. Can you reach out to him? Or they'll tell the patient themselves, hey, you should reach out to the psych onc team and do it. I also have really amazing providers and nurses within our clinics who will sometimes just call me and say, hey, Joan, I've been seeing this patient in infusion. They come once a month and they're just not themselves today. Can you please come over and see them and just kind of talk to them and see if there's something else going on? They're just not themselves. So we'll kind of just try to pop over there and offer that support and referrals to them and just kind of guide them through the process. And then, of course, as we've learned, our patients talk. Sometimes it's over at our Hope Lodge over near the stadium, or sometimes it's outside, unfortunately, on the street while they're having a cigarette. And they'll say, hey, this social worker helped me with this. Can they help me? And they told me to call you, and we try to assist with that. So we have lots of ways for patients to get us, and we're really excited to be able to help with that. Next, please. And that's a picture of our distress screening. It is incorporated within Epic, fortunately. We do get notifications now through Epic and our in-baskets, so we know who and how to follow up. So that's just kind of a little visual vision of it in its original form. Next, please. So, one of the unique things I think about our clinic and how we operate is that we are following patients throughout the trajectory of their disease. So if they are with us at the time of diagnosis, all the way out through into survivorship and follow-up. So it's through the actual continuum of care, which we're really excited about. And we try to make it very specific. Our social work team has grown enough so that we can have specific areas that we cover. We can work throughout the whole cancer center, but I have people assigned to various clinics. So we have somebody who covers in the breast clinic and the GYN clinic, et cetera, et cetera. So they're able to kind of establish rapport and relationships with these patients as they go throughout this process of treatment and into survivorship or end of life. So we just really are able to follow them and support them throughout that entire time. We also have our community partners. Sometimes when we can't fully address their barriers they may be experiencing here in-house, cancer does have is rich in resources. I will acknowledge that. There are a lot of community organizations, a lot of national organizations that can help financially support some of our patients. And we're very fortunate to have those kind of resources available to them. But sometimes it's very specific. There's not a lot of support out there for like a head and neck cancer or something along those lines. So sometimes we're still having to kind of just dig around in Google, see what we can come up with. And if you have a non-cancer related, because we do see a lot of our benign patients as well, and those are also more of a challenge and having to do a lot more community-based type referrals for them and helping them. So it's not just something that we are, if you're a Markey patient, we're going to try to help you and support you throughout that process. Not necessarily that it has to be a cancer diagnosis that gets you to us. Next, please. So this is just some of our frequent partners that we work with, whether it be here at Markey or on a national level. We are, again, like I mentioned, very fortunate to have that kind of support within the community. We have a huge outpatient clinic. I think last year we had almost 125,000 outpatient visits. On average, and my dietitians will probably have about 120 to 130 contacts a month. My social work team will have about 160 contacts per person per month. So it's a hopping in place, but that's okay because that means, we're doing our work and we're getting to help support these patients as they go through that process. And we really want to, maximize their utilization of these resources. We want to help foster their coping as they're going through this cancer process and treatment, helping them to adapt to, having this formerly healthy lifestyle potentially, and now all of a sudden they're like, why am I sick? Why am I feeling bad? So we're really just trying to look for them to cope optimally. We do a lot of psychoeducation, whether it be about the disease, the side effects. We offer support in terms of like head coverings for our patients here. Much of it is donated. And so we're kind of picky about what we take in. We have a lot of community partners who like to make us knitted caps. And so just things like that we're able to help kind of connect our patients. Next, please. So this is cancer and depression, a big thing that we see a lot here. It's underreported, it's underserved in many respects, but it has a huge volume, as you can see, of patients who actually experience depression. There's several research articles out there that's just talking about cancer and depression and the incidence of it. And so we really try to take this, as anyone should, quite seriously. And we see it a lot. And sometimes it's just a matter of normalizing that process for them. I'm seeing somebody from a clinical perspective, and they're telling me that they're run down, they're tired, they, haven't talked to any of their friends, or maybe their friends have vacated and left the picture because they don't know what to do or say. So now they're having this, this period of withdrawal. They're feeling hopeless. We want to try to help. And sometimes just saying that's not uncommon for us to be in our cancer world. It's not uncommon to have a lot of these ideas, these thoughts, these feelings that you're experiencing, but we don't want to just dismiss it either. So we try to do a detailed assessment. We'll use the PHQ-9, we'll use the GAD, and helping these patients to just try to manage and understand what that is and that it's okay to experience these feelings. We also know research has said in the past that when you are having these symptoms, oftentimes anxiety is going to come with it. So we have a lot of patients who are fearful of recurrence of their disease. They're fearful of what we call scanxiety. They're getting ready to go and get an MRI or whatever it is, and they don't want to have to do it. And you're a head and neck cancer patient, you get this mesh placed over you, and I had one patient that I worked with that she was like hearing those 4 snaps, on the corner of the radiation table, just freaked her out. So we were able to go down there and try to do some like guided imagery with her, help her just kind of, do some progressive muscle relaxation, other tools that we utilize to just help them get through that process and make them successful and being able to complete their treatment. So we also have to weigh with that the physical things that are coming on. A lot of times those physical side effects of cancer, whether it be pain, right? If I have somebody that I'm seeing for pain, I can do some CBT with you. But I'm also going to make sure that it's something that your provider is aware about and knows, and you've addressed with your provider first before I try to help from my perspective. So we're going to try to look at those things. We're also going to be looking at suicidality. We know that there's a higher incidence of suicide with patients that have cancer, and particularly in active and post-treatment, and particularly with different disease populations. However, so we're looking at these things and trying to make sure that we can help our patients and support them through this process, give them the tools that they feel like they need. We look at medications. We know that sometimes steroids as part of cancer treatments, right? And so then you have these flux of moods and feelings and thoughts. So we're trying to consider all of these things and communicating with our providers and our APPs to make sure that we are able to try to help meet these patients' needs. We also offer support groups. One that I've had for quite many years now is a knitting support group, and we call it Knit to Heal, but it can be crochet. I've had somebody do a loom. It's whatever you want to do, whatever your medium is, and you come in. And the idea is just trying to support people, provide that psychoeducation piece again. And when you have busy hands, you have a busy mouth. And so we can talk through a lot of the issues and problems that they might be experiencing as they go through this. And getting that support from other peers as well, I think is also really beneficial. There are a lot of peer support programs too that we can sometimes connect patients to. So having somebody who's been there, done that, can be very supportive for our patients as well. We do not bill currently for our services, but hopefully that, well, I shouldn't say hopefully, that's probably going to be changing soon. And so we will be looking at how that is going to impact our patient load and what we're going to be doing. I don't think it's going to be. I think everybody is really, mental health is such a big thing right now, and cancer patients are used to the isolation and the things like that have occurred since COVID. But it's still a huge factor in an increase in our services, which have grown about 200% over the last 2 or 3 years. So we're really fortunate to be able to provide this service during this time of their lives of cancer. I do also want to mention, I'm kind of jumping around, but one of the things we also like to look at is the Endicott criteria when we're looking at working with our patients. It's part of the palliative approach to diagnosing and helping our patients when they're coping with depression and anxiety. So looking more at the psychological symptoms as an aspect of the disease, as opposed to the actual DSM criteria, is something else that we kind of take into consideration too when working with our patients. We currently have a mindfulness group going on right now, and it's actually been via Zoom, and it's been actually quite a successful group. We're hoping to continue to provide that type of service, where we're trying to just teach our patients some strategies to help them cope during this time and just overall improve their outcomes and their success within their treatment plans. Our dietitians, I haven't really gotten to talk much about them. We have 2. They just implemented a malnutrition screening tool last week. So we are super busy. Yes, thank you. They are super busy trying to access our patients and provide nutritional support and counseling for them. We know that appetite can be impacted greatly, whether it be loss of appetite because of their disease or their treatment, or even just weight gain. If you're taking steroids, a lot of patients are going to put on some weight and have an increase in appetite. So also learning to do that. But more importantly, as the patients move into survivorship, our dietitians are really going to be integral in helping them maintain and learn about a healthy lifestyle to prevent recurrence and help them to just feel better post-treatment. So a lot of direction that we're going to be taking with our dietitians in terms of supporting our patients nutritionally. If you also consider head and neck cancers where you lose sometimes the ability to eat and swallow and you have tube feeds, Our dietitians are able to go in there, do a lot of teaching, a lot of support. There's a shortage of supplements right now, so we're all kind of trying to scramble and help support our patients nutritionally in that respect. But we are just a team that's able to really just provide that kind of support and that clinical approach when there's just so much going on in the chaotic world that we live, right? So a lot of times too, I love it when I'm meeting with patients, and sometimes just that normalization piece, they'll tell me, well, since I've been diagnosed, I haven't seen my friends, I feel sad, I get weepy, and I can just say, well, I've heard that before. It's not uncommon. And they're like, oh, I'm not going crazy. It's not just me. It's unfortunately part of that cancer process sometimes. The emotional side effects is kind of how I refer to it. And learning to adapt and what are the things that we can do, if it's some behavioral activation, if it's helping them to just understand how it's impacting them, if it's helping them to work on sleep hygiene. A lot of times sleep can be impacted. So that's also a really big deal. Next slide. We'll wrap it up. I know we're running out of time. We collaborate with our Markey providers all the time. We try to overly communicate, whether it be through Epic, in person, standing outside the exam room door. We want our providers to know what we're doing and how we're doing it. I think it helps with that rapport building and efficiency that we want to do when we're working with our patients and having so many patients to work with. So that was like the light version of what we do. We have just a couple minutes, I know, but any questions?
Yeah, I think there's one in the chat now. I think, are you utilizing psychologists? You seem to focus on the LCSWs. Do we have any psychologists?
No, we do not currently have any psychologists on staff. It is LCSW clinic based, and that's probably because it's me who started working here at this place. Not to say that there's not room for one, it's just not something we've been able to really get there yet. I think focusing so heavily on just with barriers to care and stuff, we just haven't been able to get to that next stage yet. But that's forthcoming, hopefully. Great question.
Any more questions for Joan? Joan, we thank you so much. What a great and robust program that you've got. I think I saw 11 social workers, and I loved how you said they're utilized, between sort of official sort of distress screenings that you've created, but also curbside consults. I think it's just another great way of that collaboration, that sort of just being there allows you to get involved and to help that. So I think that's wonderful. Thanks again for that.
Thank you.
I don't see any other questions. So I think at this point, we're going to move forward on you. So we'd like for you to participate at this point, and I'll turn it over to Mindy to get us started. This is where you pull your phone out, and Mindy's going to walk us through the next portion of our presentation.
I'm going to try. If you want to pull your phone out and scan the QR code, we are going to do a little. We want to know what your barriers and bright spots have been. If you'll just scan that QR code, Catherine's going to drop the link if you'd rather do it. Sorry, everyone, I got kicked off of Zoom.
That's all right. You made a quick recovery.
Oh, man. Okay. Let's try this again. Okay. You will scan that QR code. Catherine's dropped the link. I see people have already answered. Let me switch over to our Mentimeter so we can see this is all anonymous. So please feel free to answer. Well, technical difficulties. Sorry, guys.
Okay.
Zoom does not like me right now.
Ah, there we go.
Finally.
Yeah. All right. So we see it moving and moving and moving. So the barriers, yeah. Patients lack transportation to care. That's a big one. Pretty common to hear that for sure as well. Patients decline an outside referral. Okay. All right, lots of different reasonings for sure. And looks like some of the higher ones are transportation and declining outside referral. Anyone want to speak to those two things?
Transportation is a big issue for us here too. And we do have some internal resources through our Markey Cancer Foundation to support patients, but I know UK Healthcare as a whole, and you can reach out to the case management team. Sometimes they're able to assist with Uber type rides or yellow cabs. I've had a couple of patients who needed to come in for surgery, and we were able to send a yellow cab at 4 o'clock in the morning to pick them up in Moorhead or something like that and bring them in and just kind of try to provide that type of support. So I would just say, reach out. If you don't have a social worker, I would encourage you to speak to your practice manager so that maybe the practice manager can try to, activate other elements, whether it be within UK Healthcare, case management, what have you. But it's a real issue.
Yeah, so John, it sounds like the organization sometimes pays for it. Is that it
Yes.
basically tries, yeah, got you.
This is Ish Stevens with Ashland Children's Clinic.
Yeah.
One of our barriers really is engagement and involvement. Everybody just wants a pill. Everybody just wants a quick, easy answer. They don't want to engage in therapy. We actually co-locate. We have a co-located therapist, independent therapist that just sees our patients here, and that is a tremendous gain. The fact that they're co-located, so that's less of a reach. In the effort, but even then, it's very, very difficult to get a lot of times to get our teens to engage with a therapist. That's why I'll use the analogy. I said it's like trying to balance on a stool without all the legs there. It's like you just want the medicine to do it. It's hard to balance on that. You got to have therapy, and then you have to actually involve yourself into therapy and do the homework in essence. A lot of other analogies I won't go into for time's sake that I use for those kind of things, but that's one of that's one of our barriers, is the recognition of the value of therapy and of the effort that needs to be expended by the families. That's one of our substantial barriers.
And
Yeah,
I think one of those things is especially kiddos, adolescents are super tech savvy, and ensuring, we talked about, will the therapists have access in certain areas that, people have to call and get that information. But the other component, which I think that systemically we need to do a better job of allowing people to know who does virtual visits, because that's blown up over the last few years, but I don't know how available that information is, from insurance companies. So.
Yeah, and I think I just speak to the teens not wanting to do therapy. I think the idea that we can just fix mental health with a pill, right? And I think that's where it takes a little bit more effort, trying to explain to them and just engage. And I think that a lot of the barriers has to do with the stigma around therapy and the idea that I have to talk to someone and I don't want to talk to anybody. That's very common. And so how do we overcome those sort of barriers and explaining, it's more than just talking. And this is an additional support for you, helping with coping strategies, navigate some of the interpersonal difficulties that you may be engaging. And I just tell them, pill is just going to be like 30%. It's going to maybe help you with some, but it's not going to give you the skills and other techniques that you need to learn. And sometimes you just have to have a structure or just put some guidelines. Hey, I can only refill your medication, again, having a structure in place and how you work, collaborate, therapy and medication has to go together. And I think sometimes that requires building that trust. And at some point they do agree. I think it's, again, it's sometimes, rarely you're going to have somebody that I'm just not going to do therapy. But for the most part, I think we are able to sort of navigate and help them get into therapy. And at the same time, also helping parents understand the importance of therapy. What does therapy do to you, and what does that mean? And what are we trying to accomplish with therapy and medication? But yeah, I agree that I think just because I think as a community, sometimes, we just want a pill and fix everything. And so that sometimes take a while to overcome that.
And that's very much what we do. We'll say, look, if you're struggling, they'll come in and say, hey, I'm not doing well. I'll say, well, but you haven't seen your therapist. Before we can consider medication changes, we recommend seeing that. Real quick, I do want to just share this analogy because I think it plays into that. This is one that's been very successful for me. I'll describe to my patients that this problem that they're having, be it anxiety or depression, it's like trying to get through a locked door. Okay, you can't get through the locked door. Medication unlocks the door. Okay, and then therapy opens the door, but you still have to walk through the door. So trying to get through an unlocked closed door is not possible because it's not open. So all three of those things have to happen. And sometimes we have to have medication to unlock it because of a neurotransmitter imbalance.
Yeah.
But I've found that analogy to be very well received and very useful for them to understand that, yes, we've unlocked the door. Yes, we've opened the door. Now it's up to you. And I don't want you bouncing off of a closed locked door, but now it's open and you need to walk through. So I found that analogy to be very useful.
Love that.
Thank you for
Very
filling up
good.
our toolkit.
Yep.
That's great.
It is. It is.
All right, guys, I'm going to move us forward. We've got just a few minutes. We're going to try to squeeze that last question in. And so while we're in the process of doing that, we'll probably have to abbreviate some of our comments, but we do want to see what those things are so we can begin to wrap up. While you're answering that, I'm going to let you know that Shannon from Clean Slate has entered in some transportation resources, a link to that, which may be helpful as well. So. So what are some strategies or best practices that you found useful for managing mental health care collaboratively?
This
I
is
like that.
also anonymous, so please feel free to answer multiple times. Answers in. We won't know who did it.
Well, maybe except for the first comment.
That's true.
Yeah. Yeah, I like that. Asking for help when stuck. Absolutely. Yeah. All right. All right, guys. Well, we're going to start to wrap up. Let's do this. I want to talk a little bit about, we want to thank our speakers today. Thank them so much for their expertise. It was very helpful. And we want to thank all of our participants. This is another QR code for you. If you'll if you'll hit the button there and take that survey, that lets us know what we're doing well and ways that we can improve, guys. It's an opportunity to give us some feedback. It's super important for us there. So we do have a rich set of resources available to you that includes the recordings, the slides, all of the links, even that super cool distress screening tool that you guys saw a little bit earlier. It'll be all there on the Behavioral Health Community of Practice website, guys. Please do share with anyone and everyone. If you have any other information you think would be helpful for us to have, please send that along as well. As we wrap up, we want these sessions to be as helpful to you and your organization as much as possible. That's why it's super important for that feedback. Team, wanted to highlight next month's Behavioral Health Community of Practice session. We're going to focus on addressing patient barriers with community resources. So this is going to be a really great session. I believe we'll have our community mental health centers probably will be involved in that as well. Builds on a lot of the things that we spoke about today. So the only thing we ask is for next time, go ahead and register. Send this out to some of your friends and other colleagues from other organizations and get them hooked up as well. And to all of our presenters, again, you did a phenomenal job. Very innovative work. Thank you for supporting the team at the Kentucky Regional Extension Center. And this is the leadership team. We want to thank them for their support and expertise. And our next slide, this group makes it happen. I want to say their names. I want to say Mindy, Jenny, Lori, Katie, Catherine, Alicia, and Sydney. Those guys are the ones that put this together for us every month. They are literally the glue that holds it together and the engine that makes it move forward. So we appreciate them so much, guys. Hope everyone has a wonderful day. Thank you so much, and we'll see you again next month.